do two things at once, to assign someone as co-host while also talking, which never goes well for me. But luckily, I do not have to do it alone today. I'm very happy to be joined by the great Charmine, who is here with us today. What's up, Charmine?
I don't know about the great Charmaine.
You're right. You're right. It is
No,
the
it's not
greatest.
Charmaine. Nope, nope, nope,
The
nope.
greatest.
uh, I did set you off there, didn't I? Backward of what I wanted to do. Hi, everyone. It's so good to see you. Thanks for joining us. I'm super excited for today and to think through some medicine with you all.
Let's do it. As always for these Wednesday sessions, we're gonna keep it short and sweet with the 30-minute session today. And the goal is going to be to sort of be authentic to the reasoning process as we possibly can. Mukund has prepared an incredible case for us today that I'm very, very excited for us to get to think through. And I'm also really, really stoked to see the brilliant thoughts that are always flying in the chat as well. So please do feel free to share your thoughts in the chat along the way. And we'll hopefully make this a fast-paced, educationally rich clinical reasoning discussion over the next, I think we have 27 minutes now. So the clock is ticking, and Mukund, we will turn it over to you to get things started.
Yeah, that sounds good. Hello, everybody. I'm Mukund, second-year med student now. This is a case that I saw a few months ago while shadowing in the emergency department. I thought it was a pretty good one, just for me to learn the fundamentals and throw around a couple of interesting differential diagnoses as well. So I'll launch into this with the first aliquot, which is that we have a 59-year-old male presenting to the emergency department with a chief complaint of swelling of mouth and tongue, difficulty speaking, and sore throat for several hours.
Wow, what a start. To begin with, as you were saying, swelling and difficulty speaking, my heart rate started going up a little bit. So so the thing that is really helpful here is also the time frame of it. The fact that it's several hours and it's cute, this is something that we should urgently deal with. So whenever I think about anything that involve the swelling of the mouth and a patient who has difficulties speaking, more than anything else, I just want to make sure they can secure their airway. So this is someone that you get immediate vital signs on, and making sure they're speaking, their saturation is okay. I take a look at the back of their mouth if possible. And at all, if there's any concern for airway compromise, you want to let a lot of the times ED physicians themselves can be on alert for intubations, or you can put anesthesia. I know in a lot of other places, so get help as soon as possible. And then once you know the patient is stable, then you can think about diagnostic framework of how and why this happened. So in terms of once we hopefully will stabilize the patients, make sure they're safe, then thinking about the syndrome. Is this an alert part of an allergic reaction of some sort? Do they have hives? Do they have any other signs or symptoms of anaphylactic? Or this is something like angioedema that I will pass along, because I know the one and only Jack Penner has a really good schema for that as well.
Oh, thank you so much, Charmaine. Yeah, I'm totally with you. I think whenever we have this sort of swelling of the mouth and tongue, I think one of the first sort of reflexive illness scripts that come to mind, exactly as you said, is the question of angioedema, which usually is going to involve swelling of the mucosal surfaces of the body, particularly when we see it on the lips and tongue like this. So I will take over the screen just for a brief couple seconds to go through our CP Solver schema to think through angioedema here. Let me just pull this up here. Excellent. Are you all able to see this? All right. So I think this is one framework for us to think through angioedema that's based off of some of the possibly different mechanisms that we that could contribute to angioedema. So basically, there are sort of two primary pathways. One of them is the bradykinin mediated pathway The other is the mast cell mediated pathway. And both of these can cause, exactly as Charmaine mentioned, the sort of swelling of the lips and tongue that can lead to the problems with the airway. But one of the most helpful ways that we can distinguish bradykinin from mast cell mediated processes is the presence or absence of urticaria here. Urticaria is primarily an IgE/mast cell mediated process. So if we also see from the history or the exam findings suggestive of urticaria or hives, then we can know that we're likely dealing with the mast cell mediated category. Whereas if there's no urticaria, we may be dealing with the bradykinin mediated category. Over here on the right side, there are some of these other types of angioedema that don't necessarily fall neatly into either the bradykinin mechanism or the mast cell mechanism, things like idiopathic angioedema or certain medications, and they will variably have the presence or absence of urticaria. The good news is that these are oftentimes rarer causes. So most often than not, we're asking ourselves, is this the more common mast cell mediated process, which is usually related to something like anaphylaxis or another allergy, or the less common but equally morbid bradykinin mediated causes, which can arise in the setting of most commonly ACE inhibitor use? And so I think at this point, we'll have to see as the case unfolds whether or not we confirm that this is indeed angioedema and which kind. But this is at least one way to start to get our gears turning in terms of thinking about which pathway we may go down diagnostically here. All right, Mukund, I will turn it back to you.
Great. So I'll continue and give you the HPI. The tongue and the throat are swelling rapidly in the emergency department. Difficulty breathing is getting progressively worse, and the patient is moved to the high acuity wing of the ED for further management. Of note, the patient has poor dentition seen on oral exam and reports current tooth and gum pain.
All right. Well, I think just while we get the board up here, let me make you co-host again, Deborah. I got you. Mukund, you mentioned, sorry, you were saying that there was sore throat plus recurrent tooth and gum pain.
Yeah, that's right.
Okay, great. Well, I think honestly, what this information is doing for me is actually making me feel a little bit bashful about taking us so deep into the angioedema pathway up front, because I think some of these other findings here bring us into a bit of potentially considering some of the possible mimics that we can have of angioedema, which are really going to involve edematous or inflammatory conditions of the oral pharynx, right? We have the tooth pain and the gum pain here, which I think raise the possibility of a odontogenic or a pharyngeal infection, or possibly the combination of both. And I think while this is a space that we're oftentimes not the most familiar with in general internal medicine, it's one that's important for us to have some framework of, because it can be such morbid infections that can spread from, or I should say, such morbid conditions that can spread from the mouth throughout the other structures of the body. And so if we just think about the sort of finding of progressive tooth and gum pain that then leads to oral mucosal surface swelling over an acute period, if we're not in the angioedema/allergic reaction category, then most likely we're in the category of a progressive infection, and particularly progressive infections of the oral pharynx. And so this could be, like we were saying, an odontogenic source that has spread into the pharyngeal space or the retropharyngeal space. And again, the retropharyngeal space has the possibility to communicate with other parts of the body, for example, like the thoracic cavity. And so we're going to have to pay close attention to not only characterizing what's happening in the oral pharynx on exam, but also looking for any signs that might suggest that things have spread beyond the oral pharynx, for example, down into the lungs or into the mediastinal space as well, because these there are sort of distal or posterior structures of the oral pharynx that can communicate with the thoracic cavity. But I think beyond that, I'm struggling to make much more progress here at this point without the physical exam, because I think that that'll be so helpful for us to get a sense of whether or not this is primarily an angioedema / anaphylactic process, or we're dealing with a focal oral pharyngeal problem that is now rapidly spreading throughout the other tissues of the body. But Charmaine, I'm curious, how are you thinking about these new updates from Mukund?
Um, I have nothing to add.
Great. We'll continue then with past medical history and other associated information. Past medical history is notable for a pulmonary nodule detected 3 years ago with no other follow-up done. Hypertension, hyperlipidemia, and prediabetes. No relevant family history. Social history and health-related behaviors consist of current cocaine and tobacco use and a history of heroin use, currently on methadone. And medications include amlodipine, benazepril, atorvastatin, famotidine, HCTZ, and methadone. There are no known allergies.
Like just from the time perspective, you want to give us the exam as well?
Yeah, I can give you the exam too.
Thank you.
HEENT, normocephalic, moist mucous membranes, swelling of throat and tongue visible, poor dentition visible. Cardiovascular, regular rate and rhythm, no rubs, gallops, or murmurs. Pulmonary, clear bilaterally. Abdomen, soft, non-tender, non-distended. Neuro, mental status at baseline, no focal deficits.
Great. One question about the exam itself. Did the patient have any hoarse voice, or did you guys hear any stridors at all?
No stridors, some hoarseness, but his physician believed that that was baseline for him.
All right, awesome. And in terms of like a difficulty breathing, O2 sat, respiratory rate, everything was okay, was normal.
Oh yeah, let me give you the vitals.
Great, thank you.
Temperature 99 Fahrenheit, respiratory rate 26, heart rate 104, O2 sats 99%, and blood pressure 198 over 97. He was given a spot dose of labetalol in the ED, and his blood pressure went down to his baseline of 160 systolic.
All right, thanks so much, Michael. So kind of going back to the past medical history and kind of getting a better sense of what the background information is here. As Jack mentioned, we're like holding two spaces, right? Is this kind of an allergic reaction, or is this kind of a more progressive infection, or something else that is kind of mimicking mimicking swelling that we initially thought was like probably angioedema? In terms of his like background history, like with the hypertension, I was waiting to see if he's ever taken is he on an ACE inhibitor, because with the ACE inhibitors at any point during the treatment, you can get angioedema. Amlodipine, like the calcium channel blockers are less likely associated with it. So the medication doesn't like jump up to me as one of the causes of, the allergy type of phenomena that we were wondering about. In terms of his heart-related behavior, with the poor dentition, I'm thinking about like, a patient with a history of drug use that potentially can explain kind of the poor dentition that we are seeing. And I'm great. I'm good. It's always like good to see patients who are on methadone. It's and that kind of tells me like the patient is perhaps engaged in the type of care that they're receiving as well. So in terms of like, does the background make me make diagnostic progress that much? No, I think two things that I'm holding, like a rapidly progressive infection that I'm worried about, And in addition to thinking about like, oh, whether this is kind of an allergic response, I think the exam is quite helpful. So I'll pass along to Jack to walk us through the exam.
Awesome. Thanks so much, Charmaine. I think I really appreciate the points of particularly highlighting calcium channel blockers, which I have forgotten, even though they are listed on the schema. I've forgotten them a number of times as possible contributors to angioedema. So I appreciate that point so much. And I think, I'm right there with you in terms of holding this tension. I think whenever we have a disease process that is so acutely morbid and also requires such particular therapy, the way that something like angioedema or anaphylaxis does, making the case against it to the point where we decide to not give empiric therapy can be really tough and really challenging. And so I'll talk a little bit about sort of what features we might have here that potentially move us away from the angioedema category. But then we'll have to temper that against the realities of this person still might get empiric therapy for it, because at least for me, my comfort being wrong or in the direction of not treating is always going to favor, or how do I say this? I am very uncomfortable not treating something like this if there is enough clinical suspicion, because the devastating outcomes could be quite extreme, particularly if we don't give therapy when it is needed. But if we think about features of our illness script of something, for example, like anaphylaxis, it's really the absence of skin findings here that really help to move us away from that diagnosis, right? We said that mast cell mediated causes of angioedema will usually present with things like urticaria on exam or some sort of skin findings. In addition, we would usually expect patients to be hypotensive rather than hypertensive because of the distributed physiology that can develop in the setting of acute anaphylaxis or mast cell mediated processes. So we can say that the finding of the profound hypertension is a knock against mast cell mediated causes of angioedema, as is the absence of urticaria on exam. But as we said, there's also the bradykinin mediated pathways that oftentimes do not have angioedema, that oftentimes do not have urticaria on exam. And so now we have to contend with the fact that this still could be bradykinin mediated angioedema. Although again, I think we have maybe increasing evidence that what we're dealing with is actually an acute oropharyngeal process rather than angioedema. But I think at this point, even if the momentum is moving us away from that, I think I would still be hard pressed to not give this individual at least some of the treatments for acute angioedema to reduce the swelling and slow down the progression of it. So, for example, things like intravenous glucocorticoids up front, intravenous antihistamine medications, and then potentially, if we were worried about anaphylaxis, we might think about something like IM epinephrine. But if that's not on the DDX here, and in the setting of somebody who is so profoundly hypertensive, that could potentially make things worse. And so I think in this case, given that our probability of anaphylaxis is low, but we still have this high degree of oropharyngeal swelling that could be related to an acute inflammatory process of the mouth or something like angioedema, I think from a management perspective, we would certainly, or I think we might likely be above the threshold to give steroids to slow down the progression of the swelling, while also tempering that fact against the reality that in the acute setting, glucocorticoids are probably not going to worsen an infection if there is one there. But we would also be potentially thinking about antibiotic therapy up front as well, for those reasons that Charmaine had talked about before and that we discussed a little bit briefly. So I think that's sort of where I stand now on the exam. The pretest probability of the probability of angioedema has gone down, but is not zero. And I don't think it's gone down enough to at least not think about giving treatment to reduce the rapidly progressive swelling that it seems like this gentleman has experienced. But I'm very excited to learn more from Mukund about how this unfolded, because Charmaine and I are just conjecturing here, and the clinicians who saw the patient certainly are going to have much more of an expertise of what things look like up front, but also what the trajectory of this patient was during those first few acute and critical hours in the emergency department.
Yeah, this has been a really fantastic discussion. It's really awesome to see you both weigh the different diagnoses on your differential and compare that to how things actually went down in real life. Super, super interesting. The rest of the information I have for you will be given in one big aliquot, and the diagnosis will be revealed afterwards. CBC, whites 4,000, hemoglobin 13.6, platelets 265,000. Basic metabolic panel was entirely unremarkable, all values within normal limits. Creatinine 0.73, BUN 25, fasting glucose 107, and moving on to the imaging section. The ECG was normal. The CT neck with contrast showed extensive edema throughout the soft tissues of the neck from C1 to C7, involving sublingual, submandibular, and retropharyngeal spaces. And they actually ended up doing a scope as well, which showed edema of the epiglottis, the arytenoids, and the false vocal cords.
Sharmi, do you want to take the imaging findings, or do you want to tag team them together?
Whatever you want to do, boss.
Go for it. Go for it.
Okay. So, you know, we were just like kind of doing this dance, and as Jack beautifully said, like, you know, while our suspicion for a mast mediated might be lower, like bradykinin mediated is still pretty much at play, especially just given like the acute onset and the rapid progressive. Because the other thing to think about, like if this patient we were thinking about an infection like Ludwig or any of the infections that involves like kind of the back of the neck and is progressive, I would expect this patient to be acutely more septic, sicker, and when we present that in the vital signs, I would expect like hypotension rather than hypertension, for example. So now that looking at the imaging with the extensive edema of the soft tissue and sublingual, submandibular, and it does make me worried a little bit about the bradykinin mediated in someone who's on an ACE inhibitor that I didn't realize. Sorry, initially I skipped the ACE inhibitor, who's on ACE and a calcium channel blocker. Again, like I think my suspicion for a bradykinin-induced angioedema is high. However, you would want to make sure that you're not missing an infection. So similar to Jack, this is someone that I would treat empirically, and I would also call ENT to be able to put a scope back to also take a look at the inside and the inside as well. So that's like where my brain is going to. What about you, Jack?
I'm with you. I'm with you. You know, I think what I'm trying to do right now is to sort of pull out the illness scripts of the different diagnoses that we were considering, angioedema, again, some of these sort of deep space neck infections, and say which of these imaging findings and the clinical presentation best match here. And I think if I think about the sort of what it seems like is dominating the clinical picture here, it seems like it's primarily edema without necessarily extensive tissue destruction. For example, things like Ludwig's angina or Lemire's syndrome, retropharyngeal abscess, paratonsillar abscesses that extend. We not only can see edema and the soft tissue swelling like this, but I feel like I would expect to see things like fat stranding or potentially a signature left from gas-producing anaerobic organisms, like maybe some air within the soft tissues or some findings of the development of fluid collections. But it seems like what we're dealing with is just primarily extensive swelling and edema. Now, does that substantially reduce the pretest probability of a neck or a deep space infection? I would say it certainly doesn't take it off the table, but given what seems like a very, very rapid progression with no real pharyngitic prodrome, and exactly as you were saying, a really compelling case for the fact that there is a risk factors for developing angioedema here, I still think, and the absence of things like a very high white count, maybe a low grade temperature, but not severe fevers. I'm with you, Sharmise, that I think we have a compelling enough case for angioedema, although I'm tempered by the fact that some of those deep space neck infections can be quite aggressive. And I don't necessarily have the most well-developed illness scripts to say that this imaging finding isn't compatible. So this is a situation where I would also definitely want to talk to ENT and be like, hey, what do you all think that this looks like? And talk to the radiologist. Do we see any signs of tissue destruction or tissue inflammation? Or does it just seem like tissue swelling, which I recognize is a bit of a semantic argument here, but I really do think that if we were seeing one of these aggressive deep space neck infections, we may see more damage to the muscular structures. And again, maybe things like gas formation or things eroding across tissue planes, as opposed to just edema and swelling alone. So that I would say is probably what's tipping the evidence the most for me. But in reality, I would, I would want to talk to the ENT surgeon and ask her, like when you all see angioedema on imaging, is this what it looks like, or how worried are you for something like a deep space neck infection? And I think the other point here too is that that I oftentimes forget about, but this case can certainly remind us of, is that we oftentimes associate reactions to medications with initiation of a medication, but ACE inhibitors and angioedema are in a special category where at any time in the course of taking the medication, angioedema can develop. So even if he has been taking benazepril for ages, it doesn't necessarily mean that he can't develop angioedema. Most cases are usually within the first handful of weeks to months, but at any time along the way. So it, I think, further drives home the point that you made, Charmaine, which is that the fact that it's there on the med list raises the probability no matter when it was necessarily started. So that sort of is where I'm landing on this one. And I'm relieved to hear that you're in a similar spot, Charmaine, because that always makes me feel a little bit better. But I'm just most excited to learn more about where this case went, because I feel uncertain overall.
Yeah, I think like the other point is usually like when people come in with angioedema, it's mostly often the clinical diagnosis. So it's interesting if this ends up being in the looking at the imaging finding and the extent of it would be really cool to correlate, because the couple of cases of angioedema, we never really ended up imaging. So this is interesting as well.
Well, you all did a great job. This was really cool to hear. The final diagnosis did actually end up being angioedema. So you were spot on with that. I thought this was an interesting case to present overall. It ultimately ended up being a pretty bread and butter case of angioedema. But given the patient's history of poor dentition and current tooth pain and gum pain, Ludwig's angina was really what was at the front of people's minds. For most of the time that this patient spent in the emergency room, he was later admitted to be monitored and spent a few hours in the hospital. He had one scope done in the emergency room, and he had another scope done after he was admitted. And at that point, of course, as happens so many times, somebody came along and took a more detailed history and discovered that while he was prescribed benazepril, an ACE inhibitor, many months ago, and therefore, because the ED providers had assumed he had been taking benazepril this entire time, it turns out that he had just started taking the benazepril that he was prescribed months ago. And so this episode was one of the first times that he had taken the ACE inhibitor. It was a very interesting case. In the end, the balance between Ludwig's angina and angioedema. He was started on Augmentin preemptively in the emergency room, and when we got this extra piece of information in the history, he was taken off Augmentin and he was given corticosteroids, and his symptoms resolved shortly thereafter. Overall, also a really interesting look into the anatomy of the mouth and the neck, which I found very educational and which I hope you will too. Thanks for having me today.
Kun, thank you so much. I love this case so much because although this is, I think that this really highlights one, how challenging cases that we think of as being quote unquote bread and butter really can be. Because even if the illness scripts that we may have are ones that are familiar to us, it's oftentimes weighing competing illness scripts against one another that is very, very challenging, right? Whether it's, is this heart failure or is this pneumonia? Is this angioedema or is this a pharyngeal infection? Do we think that this person has a PE or is it all from their COPD exacerbation? When we take these common or at least familiar illnesses, but then put them in competition with one another, particularly when treatment can look so different for each of them, I think it highlights not only the diagnostic reason that we have to do, but also the management reason that we oftentimes have to do alongside this, in terms of asking ourselves, what is our threshold to give steroids in a case like this? What is our threshold to empirically start antibiotics? And would we do both at the same time, which I would say I frequently do, right? We give someone antibiotics for pneumonia and diurese them a little bit in case we think that there's a touch of heart failure happening as well. And so I think that both from a diagnostic perspective, but also thinking about the management elements, both in terms of medications as well as consultants to involve, this is a really, really rich and fun discussion to think through. And again, we sort of, not only are we in the game of sort of proving one hypothesis, but we also have to falsify the other morbid ones along the way, which was, I think, a really challenging exercise in this case. So thank you for teaching us and telling us the story of sort of how this all unfolded, because I think for me, it certainly adds a lot more richness to understanding kind of how to weigh these probabilities against one another the next time we see a case like this.
Yeah, absolutely, Mukun. This is awesome. I love these cases because this is what we see more commonly than not. So it's always fun to kind of make sure our reasoning is on par with the common things that we see. And yeah, I think Jack, your point about imaging findings of like just edema versus like, with lipid angina, you would probably see more gas, more tissue destruction, as well as like really informative because they do affect the similar compartments. And the other thing that I was kind of reading a cognitive autopsy, it was reflecting about the time course of it, and like if like angioedema, it tends to be like rapid progression involving like I'm not sure if the lips were involved here or not. So and like kind of the degree of how sick a patient is, sometimes it's really informative. But yeah, again, like it's important to hold both, as Jack beautifully said. So thank you so much for presenting. Yasmin, I can't wait to hear your teaching points.
Yes, thank you for this great case, and thank you for the amazing teaching points, teaching pearls. And what I got from this is, now the angioedema, thanks to the CP solver schemas, we can define it as mast cell mediated or bradykinin mediated. Dr. Jack and Dr. Charmaine had said that it could be, you can see if the patient has hypertension and urticaria, think mast cell mediated. And here are the causes. It can be by anaphylaxis and SAIDs, chronic urticaria. If it's bradykinin, think about ACE inhibitors, C1 deficiency, hereditary angioedema, and they can be accompanied by colicky, abdominal pain, nausea, vomiting, diarrhea. We can also have angioedema of unknown case and drug-induced angioedema, like with a special mention to calcium channel blockers, fibrinolytics, and immunosuppressive agents such as tacrolimus. Now, we also said about the treatment, if we're worried about anaphylaxis with a patient with angioedema, think about giving them epinephrine. If not, think about giving them corticosteroids that, even if it's not really angioedema, we can maintain and slow the progression of the issue in this patient. And if we found tissue destruction, gas formation, erosion during the screening test, we can think about Lemire syndrome or Ludwig's angina. I'm sorry, I don't know how to pronounce that word. Which are both infectious. One is infectious thrombophlebitis of internal jugular vein resulting from oropharyngeal infection. And the Ludwig's arises from a dental operated wound infection. Predisposing factors are diabetes mellitus, alcohol use, and immunocompromising conditions. And well, that's it. A little bit of teaching points for today. And thank you for this amazing case, Mukun.
Fast and furious from Yasmin. I love it. Thank you so much. Thank you all again for joining us today. Sharmiz, it's always a pleasure. And thank you for forging through despite what I know is some busy afternoons on service. Mukun, thank you for bringing an amazing case. and Deborah and everybody for navigating the whiteboard. This was a blast, and we'll see you all soon. Have a great rest of the day. Bye.